Hello, my name is Kelly Trokanowski, and I am the new Director of Performance Improvement here at Brownville Memorial Hospital. I've been hired to help improve the hospital's compliance with federal, state, and local regulations, and I'm presenting you today because we want to eventually upgrade Brownville to a higher patient-centered medical home. So in order to do this, we want to ensure that the hospital staff is well educated on the principles and methods of maintaining health literacy among patients. In this presentation, I will be discussing the definition of health literacy, key areas of concern and their importance, as well as recommended best practices. Finally, we will end with a hands-on training exercise. Let's begin with a working definition of health literacy. It is the ability individuals harbor to retain and comprehend basic health information so that they can make health decisions that work best for them. Unfortunately, there have been many instances in the past in which poor health literacy skills have severely impacted patients seeking health care. First, a 29-year-old woman once died from appendicitis because she misunderstood the meaning of exploratory surgery. Second, parents of a child with an ear infection once poured antibiotic medicine into the child's ear after misreading the label. While these examples may seem extreme, they demonstrate how serious understanding the health literacy skills of one's patients can be, especially in a hospital like this where the population can vary wildly. Even though there are many areas of concern within health literacy, there are two areas that we will focus on in this workshop. First, all staff will utilize the patient-friendly health education materials available and disseminate take-home materials. Second, all staff will address language and cultural differences. The importance of each of these areas cannot be understated. Just looking at statistics from the U.S. Census, it was found that only 12% of adults have proficient health literacy. This is further compounded by the fact that less than 50% of U.S. adults feel their healthcare providers spend enough time with them during visits, so those with poor health literacy are not nearly getting the attention they need. And if enough time is spent with them, take-home education materials are often written at too high a reading level, and many healthcare professionals don't use recommended strategies. Furthermore, patients with poor health literacy are on average much costlier than those with adequate health literacy. Therefore, improper care of these patients affects everyone in the hospital. Additionally, since Brownville services a community in which 35% of the residents speak a language other than English at home, addressing language and cultural differences is critical. This is even higher than the national U.S. average of 21%. Also, even those residents who do report speaking English often report not speaking it well, also known as having limited English proficiency, or LEP. In fact, because this combination of cultural barriers, low health literacy, and LEP can often lead to poorer health outcomes, the Joint Commission refers to these types of patients as triple threats. Now, since the investigation of culture and language as determinants of health literacy has been unfortunately limited, it is up to us as healthcare providers to fill in those gaps and meet the needs of these patients. The importance of health literacy is further evidenced by the existence of numerous national policies, programs, and interventions available to improve these skills among patients. Some examples include the Plain Language Campaign, whose goal is to increase the use of plain language and improve communication skills among health and insurance professionals. The Health Literate Care Model, which advises that health literacy become an organizational value infused into all aspects of planning and operations in a healthcare setting. And the National Class Standards, also known as the Cultural and Linguistically Appropriate Services Standards, in which healthcare organizations are obligated to offer language assistance to LEP patients and/or those with other communication needs at no cost to them. However, the most distinctive example is the National Action Plan to Improve Health Literacy, which was developed by the U.S. Department of Health and Human Services. The plan is based on the principles that 1. Everyone has the right to health information that helps them make informed health decisions, and 2. Health services should be delivered in ways that are understandable and beneficial to health, longevity, and quality of life. Each of these national policies and programs mainly promote the key communication principles that must be employed when addressing these health literacy issues. First, the way health information is communicated is critical. For instance, providers should speak in short, simple sentences that are slow and clear, as well as conveyed with a positive and supportive tone, which will help patients retain information more effectively. Also, providers should solicit questions from patients, which will help providers determine patient understanding. There are methods that align with these chosen issues as well. For instance, the teach-back method is a way of checking understanding by asking patients to state in their own words what they need to know or do about their health. It is a way to confirm that a provider has explained things in a manner that patients understand. The related show me method allows staff to confirm that patients can follow specific instructions. Furthermore, there are certain aspects and best practices that healthcare providers should use when communicating with patients, as well as practices that should be avoided. First, for take-home materials, large fonts should be used, as well as clear headings and layouts so that proper attention is paid to key points. Also, the text should be kept at a 5th grade reading level, since most adults read at a level lower than the last level of education they achieved. It is also important that materials take advantage of using visuals like graphics, which help patients interpret more complex information and helps providers reinforce written and spoken messages. Finally, it is critical that an educational material use entirely plain language and avoid using medical jargon, which may confuse patients. If medical terms are used, their definitions should be explicitly stated in the document. Additionally, for language and cultural differences, offering language access services like interpreters and translated educational materials is best for those who may speak languages other than English. However, it is also important to maintain cultural competence by being receptive to diverse cultural health beliefs, respectfully asking patients questions about their cultures and customs, making no assumptions and harboring no biases. Overall, when utilizing these practices, the ethics at play must be considered. For instance, you should never assume that just because you understand the health information being taught, that the patient doesn't need to. This would be a violation of the patient's autonomy and could keep them from making informed health decisions. Now that we've gone over the key areas of concern and the best practices for addressing them, we are going to complete a hands-on small group exercise so that we may apply these principles and strategies. The purpose is to practice clear health literacy methods that can be used directly with patients, discuss patient education material readability, as well as improve cultural competency. Basically, everyone will review examples of take-home educational brochures, determine whether they meet patient health literacy needs, and advise how they could be improved for those with language and cultural limitations. Just to reiterate, this exercise is meant to address our two key areas of concern simultaneously, so that we are better able to meet patient needs in the future. The materials needed will be very simple. We will use a typical conference room with tables and chairs. I will be providing scrap paper, pens and pencils, as well as 3 different examples of patient education brochures that have been used as take-home materials in the past here at Brownville. Finally, I will be providing a SMOG readability formula handout, which is a technique often used to determine the readability of written materials. The handout will explain how exactly the method is used in relation to determining readability. Basically, if a person reads at or above a certain level, they will understand 90 to 100% of the document. In the first step, we will be reviewing take-home education materials. For 15 minutes in groups of 3, everyone will discuss their patient brochure. You will determine how readable and usable the information is based on the recommended practices. You will also calculate the brochure's grade level using the SMOG readability formula handout. Once the 15 minutes is over, each group will present 1. The grade level of their brochure, and 3 examples of how to improve the brochure's readability. In the second step, we will identify cultural and language barriers. First, for 10 minutes, in the same groups of 3, you will discuss the same patient brochure you assessed in the first step and determine the cultural and linguistic appropriateness of the information. Once the 10 minutes is over, each group will present 2 examples to improve the cultural and linguistic appropriateness of the brochure and 1 example of a language resource available here at Brownville. The expectation is that all participants will be able to assess the readability and cultural appropriateness of take-home education materials. Not only that, but you will feel more comfortable discussing these subjects with your peers in the future. We will also report back in 30 days and have a 30-minute discussion with all participants. We will discuss whether the lessons learned were applied in daily activities, and you will be asked to take a brief survey so that we can rate whether training was effective on a 1 to 5 scale. I do hope that everyone is able to utilize the principles taught here in a useful manner. If you have any further questions, please do not hesitate to contact me directly. Also, please feel free to use the citations I have listed here for your own research. Thank you again, and have a great rest of your day.